All right. Hello, everyone. Today's topic is cardiopulmonary resuscitation. We're going to do a little bit of a review of the basic of resuscitation, primarily basic life support, with some hints of advanced life support. But the point is to formalize the approach to cardiopulmonary resuscitation in cats and dogs, and that's what the aim of the recovery initiative had been for the past 5 years. Recovery Initiative was a veterinary specific update on resuscitation, and that took initiative from the human side, where for the past 20 years they have been doing the same thing, which is reviewing the evidence and then put it into clinical recommendation based on the power of the evidence and the clinical significance of the results and outcome from trials that investigated such interventions. So, as I said, the guidelines of cardiopulmonary resuscitation originate from, at the basic level, from bench studies and animal studies that then were applied to clinical practice in humans, that those studies allowed to determine what were the recommendations on the human side. From the work that the reassessment campaign on veterinary resuscitation had done, they basically used the same studies because were human studies to begin with, and the vast majority were done in dogs or pigs. And then based on those, they tracked back to see if there was any clinical support of the application of such intervention in cardiopulmonary resuscitation for small animals. And the recovery is organized in 6 major domains. The domains are preparedness and prevention of cardiopulmonary resuscitation, basic life support, advanced life support, monitoring recommendation during cardiopulmonary resuscitation and following cardiopulmonary resuscitation, and post-cardiac care, post-cardiac arrest care. And then the last topic, it was a separate area, which also unfortunately is relying on a very, very little evidence, is large animal CPR. Today's the points that we're going to cover are primarily preparedness and prevention, basic life support, some aspects of advanced life support, and monitoring. Post-cardiac arrest care is a very large topic that certainly cannot be summarized in a single lecture. So as you see from these pictures, we are not that different from humans, or our patients are not that different from us. And so that's why the application of physiology is not very different. Small animal CPR is a first update on the recovery initiative in 2012. And as I said, the primary goal was to develop a set of clinical consensus guidelines that would apply to clinical CPR, and then review the literature, both human and veterinary, to determine the applicability of those. So the scheme adapted from the ILCOR is the same that the Recovery Initiative used. The ILCOR is the International Liaison Committee on Resuscitation, and each guideline is supposed to be approved only once it had a recognized class of evidence and a level of evidence. Meaning the class will define whether the risk-benefit ratio of such intervention, whereas the level of evidence tells you what the strength of publication supporting the recommendation is out there. For what concerned the first domain of the Recovery Initiative, preparedness and prevention is the first that was investigated. So CPR training is a well-recognized tool to optimize patient care in a time of crisis. As for any contingency planning that is done, training of the team that will deal with the emergency, no matter if it is a fire in a building versus a flooding in a city or CPR on a patient, preparing a team that is formally certified to intervene will optimize the patient care, especially in a situation where obviously in cardiopulmonary arrest, every minute or every second count to favor the positive outcome for that patient. Having a team of people prepared univocally and formally on how to proceed in terms of prioritization of intervention would be the best way to optimize and favor positive outcome. And that is actually considered a class 1 level A recommendation, meaning there's certainly strong support at doing CPR training and repeat CPR training normally every 6 months in every human hospital. In veterinary medicine, we're lucky if we do it every other year. But at least the recommendation is there, both on the human side and the veterinary side, that with short sessions of understanding the principles of CPR, especially basic life support, there's a drastic increase in outcome on cardiopulmonary arrest patients. The second aspect is the team dynamics that is important to be understood during crisis situation. In a crisis situation, there can only be one leader, one person that determines the situation, determines the severity of a situation, and leads a group of people that works unanimously and in synchrony to optimize the outcome. So it's always important in defining a CPR team who is going to be the leader. In veterinary medicine, normally is a little bit of an unfair situation because in a most case scenario you have one or two people available, so you don't have much of a team to work on. But should you be lucky and be part of a team that can afford to work together on a cardiopulmonary effort, then in that scenario, normally what is understood is that the person with the highest level of skills in the field of resuscitation would be taking the lead, and the rest of the team would be coordinated by that person. The leader is primarily responsible of tracking the situation, communicated to each team member what its role is, and also organize the team in a way that recognizing that one of the team member is in a challenging situation, replacing it or substituting the intervention with another individual. So that is what is the second important aspect, and was defined clearly in human medicine as a strong advantage in a positive outcome, but also in veterinary medicine. So it's also a class 1 level A, which means stronger recommendation or strong recommendation to do so with a level A, meaning there's sufficient evidence behind it. Basic life support. Basic life support is basic, but it's not trivial. Is potentially the most important aspect of CPR. You could be an expert on defibrillation, you could be an expert on ECMO, but if you do not do basic life support properly, your cardiopulmonary arrest patient will still die. So what we know about basic life support is the sooner it starts, the better it is. How soon? For every minute delay, mortality rises. So from the time that the cardiopulmonary arrest occurs, every minute you have an exponential rise of mortality, where following 6 minutes on the average patient, the chances of full recovery of the patients, they are negligible. So 6 minutes really is the time where you definitely want to start CPR from the time of cardiopulmonary arrest. Starting any later, you will already have strong consequences, primarily to the brain function and central nervous system, that are very likely irreversible. The exceptions are always there, and obviously patients dying of drowning, patients dying in hypothermia, and patients that are neonatal, they will have a much higher chance of recovery despite prolonged delay from the time of arrest to the time of initiation of cardiopulmonary arrest. The longest delay ever seen was 6 hours. So a kid that was dead for 6 hours, found in the water, and was resuscitated, is a pretty impressive, and he returned to normal function. He's now an adult, and actually I think it was a woman in Alaska, a kid. But anyway, so that is a little parenthesis. But so the delay, obviously, as I said, exceptions in medicine are the rule. But when to start basic life support? As I said, the sooner the better. So what are the aspects that are the most relevant? recognizing cardiopulmonary arrest. Obviously, you want to be able to recognize it as early as possible if you want to start as early as possible. The second step is unequivocally chest compression. Nothing else should take priority over initiating chest compression in the recognition or high suspicion of cardiopulmonary arrest. Nothing else, no airway management, no provision of ventilation will take priority over chest compression. This applies to pediatric and adult CPR. For neonatal CPR, we are going to have a separate session where I will identify the differences from adult. But for any pediatric patient or adult, meaning any patient that is not just born, then chest compression will have always the priority, and if you are alone, all you'll be doing is chest compression. You don't ventilate, you don't do anything. You scream for help and you do chest compression. That's all you'll be doing. So, how to recognize cardiopulmonary arrest? Well, the rules on that also have drastically changed, where for years, palpating the pulse or try to define whether if there were pulse or not was an important aspect at defining whether the patient was truly in cardiopulmonary arrest or not. What was found out is that a patient in cardiovascular collapse might have enough weak pulses that might not be easily detectable, especially by people that are not equally trained. And that will create a delay in initiating chest compression should that patient really be dead. Because if you take a minute to decide whether there's pulse or not, that minute still is, if that patient is truly dead, a delay from initiating chest compression. So actually determining whether the pulse is there or not is no longer whatsoever an important aspect on initiating chest compression or recognizing cardiopulmonary arrest. Obviously, as you see here, sometimes finding the pulse could be hard in our patients, and I wouldn't recommend it in a porcupine because that's gonna be painful. But so do not, as a general rule or a first rule, do not waste time at debating presence or absence of peripheral pulse. If the patient is unresponsive, is not breathing, or you can't tell if he's breathing at all, start chest compression as soon as possible. That is the only two things that you need to be aware of. No responsive, not breathing, or not sure if he's breathing. You do not do anything else other than scream for help and start chest compression. Or if you are lucky and you have a bell, ring the CPR bell. By the way, we're gonna have one. Basic life support chest compression. So you're gonna start them as soon as possible. And ventilation management, as I said, but I want to reiterate it, should not delay chest compression. Should not delay chest compression. Lateral recumbency for both cats and dogs is recommended. The class of recommendation is a class 1 and the level is B. The reason why is a B recommendation is that there are also studies that say that in a dorsal recumbency it is possible to do adequate chest compression, especially in barrel-chested dogs. Bulldogs normally are the ones that are round enough that you can put them on their back and squeeze ventrodorsally. Whereas for all other patients, lateral recumbency is the easiest position to maintain the patient in an adequate position and compress the chest to the adequate amount. Left or right recumbency, there's no difference, so there's no need to flip it as if it's on one side or the other. The higher left ventricular pressure and the aortic flow is reached in a lateral recumbency compared to a dorsal recumbency in deep-chested dogs. So that's why, especially if you have a deep-chested animal, certainly you want to stay on a lateral recumbency. And you have a higher rate of resuscitation when you keep it on a lateral recumbency compared to dorsal. External chest compression, they rely on two major theories. The theories that allow movement of blood across the vasculature during chest compressions are the thoracic pump theory and the cardiac pump theory. The thoracic pump theory relies on the fact that putting pressure on the widest portion of a chest will rise the intrathoracic pressure, and that will generate flow out of the thorax. Whereas during the recoil of a compression, then you're going to have a refill of the thoracic cavity that then will be squeezed across the heart and then pumped around the body. During the compression, also you're going to have the aorta being compressed and the vena cava that is collapsed. So by collapsing the vena cava during the compression, there's no further inflow of blood into the chest, but only blood squeezed out of the chest. And by compressing the aorta is bouncy, so once it's compressed, the elastic recoil will allow push forward of blood. For what concerns the cardiac pump is what relates to small dogs or cats, where you can actually hold on to your hand the cardiac silhouette, and the cardiac volume will be within the palm of your hand. So in that case, you don't squeeze the chest, you just squeeze the actual heart from the actual chest wall. So the direct pressure over the heart will then compress the ventricles, and that will generate the outflow of blood. And that will increase the left ventricular and aortic pressure, and that will generate blood flow. The elastic recoil, as I said, is what is just as important as the compression. We'll see some rules on how the compression have to be done, but the elastic recoil is fundamental to favor refilling of the chest with blood to then be pushed out. Doesn't mean that the pleural cavity filled with blood. If that's the case, you need to do an open chest. It means the thoracic cavity, meaning the organs and the vessels within the thoracic cavity. Obviously, major vessels, lungs, are the one that you want to feel first, and then the heart next. So the decrease in intrathoracic pressure that occurs during recoil will then increase the peripheral blood flow into the thorax and then circulating blood through the lungs. So the chest compression recommendations, if you want to summarize it in short, push hard and push fast. However, not too fast. And the reason being is that it's important to maintain a rate of compression that is sustainable, that will not affect the quality of a compression. Meaning, if we, human beings, were able to maintain a rate of compression of 180 beats per minute, or compression per minute, that would be likely better than the recommended one of 120. However, maintaining a compression of 180 is sustainable, but unlikely doing it adequately with the appropriate recoil is sustainable for any sort of time. So that's why the recommendation of compression is between 100 and 120 compressions per minute in cats and dogs. The important aspect about the compression itself is that you want that such compression will squeeze the chest by at least 1/3 up to a half of the width of the chest itself. So it needs to be a heavy, forceful compression that would allow to compress it to 1/3 to up to half of it. Even more important than this, as I said, is the full recoil. You don't want to lean on the chest. You don't want to put too much weight on the chest wall. You want to allow the full recoil of a chest between compression from one to the other. And then you want to do uninterrupted cycle of 2 minutes compression, and we'll see why. The reason why is recommended to do at least 2 minutes is because to achieve about 20%, between 10 and 20%, depending on how well performed are the compression, of the natural cardiac output that the patient has when he's alive, it takes about 45 seconds of perfect compressions. So it takes you 45 seconds of perfect compression to achieve about 10 to 20% of the cardiac output that that dog or cat has when he's alive. That is also the most that you're going to be able to do with your external compression. So because of that, it takes you 45 seconds to get there. At least maintain it for a minute before you have any interruption that will, within a few seconds, will make you lose completely what you have achieved over that time period. So that's why the 2 minutes compression. Interposed abdominal compression. Interposed abdominal compression are still part of the basic life support. They are only recommended if, and only if, there's an available person that is there doing nothing and can assist but is not used for any other purpose, and we'll see there are many other things to do during resuscitation. The interposed abdominal compression are compression that are done intermittently to the chest compression. So they are done at the same rate, and so you compress the heart, you compress the chest, while the abdomen is let recoil, and then you squeeze the chest while you're recoiling the you squeeze the abdomen while you're recoiling the chest. So it's just an intermittent sort of bellow system that is done to maximize the venous return and favor blood flow from the abdomen into the chest. As I said, it's a class 2 recommendation, and there's not much evidence of abdominal trauma associated with it. Ventilation recommendation. So that is more related to chest compression. Ventilation recommendation, never do it too fast, and never do it, or at least if you do it, don't do it too slow either. But no, not too fast is the most important aspect. Rapid intubation without interrupting chest compression is a level 1 recommendation. So ideally, you should be able to intubate the animal while somebody is doing chest compression, or someone should be able to intubate the dog while you are doing chest compression, so you do not interrupt to intubate. Avoid high respiratory rate, avoid long inspiratory time, and avoid high tidal volume. Why? Because all these actually will impair venous return. By doing a positive breath, you will increase the pressure within the thorax, and you would impair the flow from the abdomen or from the cranium back into the chest of blood. So do not do high respiratory rate, do not do long inspiratory time, do not do high tidal volume. For recommendation, about 10 breaths per minute, 10 ml per kilo of tidal volume if you have a system where you can measure the tidal volume of a breath. Short inspiratory time of 1 second. That is a recommendation. Rapid intubation. It's obviously easier to say than done, but obviously if you are alone, you might not even attempt to intubate because it will take too long and too much delay. So you start chest compression, and you can do mouth to snout technique. There are no studies that examine the efficacy of mouth to snout ventilation in dogs and cats, and there are no studies that are investigating the optimal compression to ventilation ratio of not intubated patients. If you're not able to intubate, the compression to ventilation ratio of 30 compression to breath is recommended, and that is a class 1 level B. So if you're alone, you don't have any help, or you cannot intubate this dog, you will do 30 compression to breath, 30 compression to breath through the snout. In rabbits, there's a nice publication describing CPR in these pieces. The biggest challenge in this animal when they're healthy is doing orotracheal intubation, and this study showed that it was possible to do successful CPR in bunnies just with tight fitting mask, face mask, without trying to intubate them. So the recommended now technique of CPR in a bunny follows the same lines of cats and dogs, but do not try to intubate them. You just do face mask ventilation, and actually they prove a pretty good success rate. Basic life support in terms of key recommendation: rapid recognition of arrest and rapid initiation of chest compression, immediate initiation of chest compression over anything else. Intubation and ventilation are performed during the chest compression. Ventilation rate of 10 breaths per minute without interruption is what is recommended. Chest compression, compress about a third to a half of the lateral recumbency width of a chest, and 100 to 120 compression per minute. You want to allow complete recoil and do 2 minute cycle of uninterrupted chest compression with the change of a compressor at every cycle. So each person should stop after 2 minutes, and that was shown that independently from the degree of fitness of the person that is doing compression, following 2 minutes of it, he will start losing intensity on the compression. Regarding monitoring is the time spent checking for pulses should always be avoided. The chest compression should be initiated as soon as possible for any unresponsive patients. The monitoring system, they are necessary to determine what intervention is needed for that patient, and also to determine the efficacy of the compression, are ECG, so electrocardiogram, and end-tidal CO2. Those are the two monitoring systems that should be available in any scenario where cardiopulmonary resuscitation is performed. The ECG should be always connected to evaluate whether the rhythm associated with cardiopulmonary arrest is a shockable rhythm or non-shockable rhythm. It's not for a diagnosis of the arrhythmia, it's to decide whether if this patient needs the use of a defibrillator or not. The end-tidal CO2 is the tool that is important for many reasons. One, allows to recognize intubation. Should not be used as the only tool to recognize, to confirm intubation, but certainly is an important tool to help in identifying whether the patient is properly orotracheally intubated. The second is that it's been recognized as a useful tool to define the efficacy of the compression. If you're able to maintain an end-tidal CO2 above double digit, so above 10, during chest compression, those chest compression are deemed efficacious to maintain some sort of support of cardiac output. The third aspect associated with the advantage, recognized as an advantage of end-tidal CO2 over other tools of monitoring, is that if you all of a sudden have a drastic increase on your end-tidal CO2, that can only be associated with return of spontaneous circulation. So if all of a sudden you see a spike on the end-tidal CO2, that would represent the fact that that dog had a return to a heartbeat, and now is promoting blood flow spontaneously. The pauses during the chest compression are only aimed to evaluate the ECG and should be minimally extended. So a few seconds, less than 10 seconds should be the most that you leave the patient uncompressed, and they should not be more often than every 2 minutes. Yes. Check.